Hello classmates, my name is Naomi Brenes. Today I will be presenting my literature assessment and proposed research question examining the fiscal impacts of healthcare policies. The Patient Protection and Affordable Care Act of 2010, better known as the ACA, stands as one of the most consequential policy interventions in modern U.S. history. It is often compared to the creation of Medicare and Medicaid in 1965 for its scope and ambition. The ACA aimed to achieve four major goals: expand insurance coverage, advance health equity, invest in prevention, and slow rising health costs. But its passage was just the beginning of a decade-long political and legal battle. Not a single Republican voted for the bill. So, repeal became a rallying cry from day one. In the legal battle of National Federation of Independent Business versus Sebulus in 2012, the court's decision upheld the individual mandate by redefining it as a tax, while making Medicaid expansion optional. This created a sharp policy division between the states. Politically, both sides claimed victory, and the following decade was marked by lawsuits, repeal efforts, state resistance, and intense media scrutiny. The literature consistently identifies three interrelated policy themes that reveal both the ambitions and the limitations of the ACA. First, coverage demand expanded dramatically. About 18 million people gained insurance, largely through Medicaid expansion and the new marketplaces. Yet coverage did not guarantee completion. Persistent gaps remained, especially in non-expansion states and among individuals facing affordability challenges, administrative hurdles, or cultural and political mistrust. Second, equity and intervention initiatives, such as the Sections 1557's anti-discrimination protections and the Prevention and Public Health Fund, were designed to address structural disparities. These efforts showed real promise but were implemented unevenly, often constrained by provider shortages, variable state participation, and lingering public mistrust. Third, cost control strategies successfully slowed federal healthcare spending growth, mainly through Medicare payment reforms and efficiency initiatives. However, these savings often failed to reach households as deductibles and out-of-pocket costs continued to rise. Anti-fraud provisions like the Anti-Kickback Statute, Stark Law, and the False Claims Act were also introduced to reduce systemic waste and strengthen program integrity. These measures have the potential to shape how financial burdens are distributed across the healthcare system, though their broader fiscal effects remain understudied. Taken together, these themes highlight a central tension. There's a gap between the ACA's policy design and its real-world fiscal outcomes. And this is where my research question emerges. To what extent did the ACA redistribute the financial burden of healthcare among taxpayers of different income levels in the United States? To answer this, I propose a quantitative explanatory research design using longitudinal comparative approach. I'll examine pre- and post-ACA fiscal impacts across income groups through secondary data analysis from IRS tax data, CMS spending reports, CBO fiscal assessments, and MEPS household expenditures. Analytically, I'll apply descriptive and inferential statistics, time series, difference and differences, and distributional techniques like Gini coefficients to assess cost shifting over time. Following Wallyman's methodological framework, this approach allows systemic evaluation of policy impact over time and measures relationships between key fiscal variables. Thank you for listening to my oral discussion. I look forward to reading your responses.